This is my disclosure slide. For years I have done tubes, and this has had been my partner for last 6-7 years. And for last 3 years, I have been flirting around with my new found girlfriend, which is the endoscopic spine surgery. There are many ways if you are thirsty to drink water, and this is how you can dig a pond and get the water, or maybe some tubular people will put a tube and get the water from there. But if you are as enthusiastic like me and you want to do things, look at things up close and personal like this, you have to be endoscopic spine surgeon. That is where I am today. So, just to give you a brief, there are two ways to do it. You can be an interlaminar, which is the classical traditional approach. It's a familiar approach, a versatile approach, and you can do big disc. You can do everything what an open or a tubular guy can do. So even a big disc like this with foot drop, all you need to do is to go there, and you can remove even up to 20 small pieces of disc fragment. And patient, of course, do very well. And if you ever had a doubt that you cannot do this endoscopically, these are post-operative MRIs for you. You can see not only that it shows that there's complete removal of the disc, even a very, very large fragment. And this is where you are, minimal incision and maximum intervention. The other approach is transforaminal approach. You go through the transforaminal corridor, and especially I prefer for cases like this, a higher level disc, a central disc, where you really need to go and just take out that fragment without doing anything. No matter what you do, whether you're an open surgeon or a tubular surgeon, this has its own challenges when you're approaching a higher level central disc. But through endoscope, only you need to do is target that fragment, go out there, just reach the fragment and take out the disc. That is all you need to do. And that is what was done here. You can see this is where we are. We are exactly at the disc where it's supposed to be. And you reach the disc fragment, you take out the fragment, and that is where it is. And again, just to show you, this is the post-operative MRI showing a complete removal of the disc fragment. So when we went through the journey of converting from open to tubular, we did review all our data, and we did came up with few of the publication. This was comparison between tubular and open surgery, and these are some of the results we got. Similarly, when we were converting from tubes to endoscopy, we did follow our data. And this is a not peer-reviewed data, but when I looked at the literature, I didn't find anything better than this. So this was our cases when we were doing both tubular. As of today, most of my cases are now endoscopic, but this was transition when we were shifting from tubes to endoscope. So all our patients were compared, and we analyzed the data in terms of VAS and ODI, and even we looked at the preoperative CRP and CPKMB, and we analyzed the data. And this is the data for you. There were 112 patients in endoscopy and 90 in tubular group. And most of the demographics, as you can see, is comparable. Now, if you look at the VAS code, and I'm giving you post-operative data because we do have now 1 year follow-up, but that is yet to be analyzed. If you look at the VAS score, in post-operative period, the VAS score was almost similar, but look at the ODI. ODI score for endoscopy was much better. Look at the CRP and CPKMB, which tells you the muscle damage that happens when you do the surgery. And this is just a comparison of the CPKMB and CRP. And CPKMB and CRP were significant less, which tells you that there are less muscle damage. And so the outcome and the recovery has to be enhanced. And if you look at the data, and this is from the latest publication in 2020, the Anthony Young, if you know him, he's the father of modern endoscopic surgery. And this is a huge data from 442 patients. And Anthony Young group basically promotes the transforaminal approach. And they say that up to like almost 83.7% of their patients had very good results. And they had a significant reduction in their VAS and ODI scores. And the return to work after endoscopic spine surgery were 92.5%. So there is still a lot of debate and a lot of lacuna of literature comparing all the groups, and that is where we have tried to do some of the things. Although endoscopic approach for abdominal surgery or arthroscopy for knees is a proven technique and no one does it open, but as the data is coming and as what we are seeing, there's no doubt that endoscopy will show you that it has better recovery. Why it is important, not only that it can do everything which an open or a tubular surgeon can do, it opens up new frontier, and that is where it's a game changer. She's a 32-year, 110 kg female. She came with a disc prolapse. Not only there are disc prolapse, there is osteophyte here. And I think only way most of us will treat her is to, because you need to remove the osteophyte, you have to mostly go for a fusion. But we had other plans. We went endoscopically. What you can see here is not only the disc fragment was removed. If you see what we'll do with endoscopic burr, we tracked those osteophytes, and we could burr exactly those osteophytes. And that is, you see that those endoscopic burr is doing. How we can do it, that is the beauty of navigation. You navigate your endoscope, and that really gives you an edge when you're doing this case. Again, this is my case done some eight years back when we did an open laminectomy. You can see a big laminectomy scar, and he presented after 8 years for 2-level disc prolapse, and this is what we did. Both the discs could be done with endoscopic spine surgery. Again, this was during COVID era. A 54-year-old female, she was CKD, hypertension. She had absolutely white lungs. She was unfit for any type of anesthesia, and she was a case of discitis. So what we did is, again, we did endoscopic discectomy under local anesthesia, because that is what our anesthetic could only give us. They said, you cannot do anything else. Not only we went there, we gave a lavage, we took out that fragment, but also what we did is, through that scope, we sort of, that time, we put some allograft, because that is what we thought we could do. And she was planned for a fusion later, but 3 months follow-up, the area we have put the allograft, she completely fused. Not only this, we have now 19 cases where we have done, and this is one of the accepted paper where endoscopic solution for spondylolischitis, which I will be presenting in Global Spine Congress. It again allows you faster recovery and reduces complication. This is a case of a dural tear in endoscopic spine surgery. You can see there's a small dural tear here, and one of the rootlets is coming out. But on the other side, you have a post-operative MRI, because once you come out, there is a contained leak and nothing happens. Why nothing happens? Look at this video. This is the only thing, even the phlegm is completely intact. As you come out through your scopes, layers and layers of muscle will simply fall back. And that is what allows you to, have a contained space. So even a small dural tear is not at all a problem when it comes to endoscopic spine surgery. And that is the beauty of endoscopic spine surgery. Just like your mobile phones are evolving, so it has been my surgery evolving. And this has been our evolution throughout the time. So with this, I leave you with this message that endoscopy is one versatile technique which allows a surgeon to tackle a range of pathology from cervical to lumbar spine. Endoscopic approach allows faster recovery, reduces complications, but it does come at a cost of a steep learning curve. But at the end, you should do what works best in your hand. Let me leave you with this message that fast surgeon is the one whose patient gets discharged without complication and are able to get back to their job at the earliest. Time has come to measure from onset of illness to return to work or back to work, and not from skin to skin. Thank you so much.